here. Now Dr. JALPA VASHI will be speaking on NABH protocols in endophthalmitis. So in addition to the AIOS guidelines, we also need to have an idea of what the NABH wants us. So Dr. JALPA's talk will be dealing with just that.
Good morning, everyone. And I would like to thank Dr. Hemwanti for the opportunity. So endophthalmitis, in fact, none of us would like to have it. But in case, unfortunately, if it happens, then how many of us are prepared to tackle the same? So let us learn a couple of guidelines laid down by the NABH, which will help us in preventing the infection and will safeguard us with proper documentation in case the infection happens. Now, who is responsible when ENDOPH happens or in any kind of infection happens? Is it the operating surgeon, the OT nurse, CSST in charge, the OT support staff, or infection control nurse? Or altogether consumables like BSAs, intracameral drugs, IOLs, or it can be process failures also. There can be improper validation of sterilizers. There can be failure in indicators. If the surgical safety checklist is not executed properly, if reuse policy or multi-dose vial policies are not defined, then all this infection can happen. Or the entire infection control program, which would lay down all these policies. So in NABH, there are 10 chapters. Out of 10, 4 chapters would guide us regarding infection control policy, documentation, and quality assurance. So let us first learn a couple of guidelines which will help us in preventing infection. Now, in inpatient record, this is discussed by Dr. Mathur. Couple of things are mandatory to be mentioned as per guidelines, like negative history of MGD or SAC block, any systemic illness or uncontrolled infection. Consent is very important. We know that is a legal document and it should be filled properly and it should be bilingual also. Surgical safety checklist, we'll discuss this. Operative notes, IOL implant details. So the IOL label, which carries the details, should be pasted at 3 places. One is the OT master logbook, another one is your discharge summary, and then inpatient record. Post-operative care plan, which will include your antibiotic protocol, and discharge summary. Here it is very important to mention about how and when to obtain an urgent care in case if some untoward things happens. And this should be in the language which patient understands. So this is the surgical safety checklist, which is laid down by WHO in order to provide safety for all the patients who are undergoing surgeries. Now, this can be modified as per our need also. Here you can see the 3 phases: sign in, time out, and sign out. Sign in is before induction of an anesthesia, time out is before incision, and sign out is before patient leaves the operation theater. Now, in sign in, you have to identify the patient's patient and patient's site of surgery, and again consent. In time out, your nursing staff will review the indicators and also the antibiotic, whether it is given as per the protocol, the prophylactic antibiotic. Here you can also include the verification of IOL power. You can also include the verification of all the vials or consumables which are going to be used. Coming to operation theater, Dr. Hemwanti is already mentioned, but avoid mix of sterile and unsterile stuff. And there should be, SOP on safe usage and sharing of consumables to ensure the safety when we are sharing the consumables like BSS, Tripan Blue, or any intracameral drugs. And documentation of each consumable should be mentioned in the surgery patient record. Coming to quality assurance program regarding OT surveillance, the efficacy of the OT cleaning and disinfection practices should be ensured, and this should be ensured by taking OT cultures. As per guidelines, once per month we are supposed to take OT cultures, but if there is a heavy load, then you can take once in 15 days. AHU monitoring, it should be daily for humidity, temperature, and pressure differential. The integrity of AHU filter should be checked once in 15 days. and CSSD surveillance. Now, we assume that when the indicator changes the color, the process is executed properly, but it is not so. It just indicates that process is completed. It doesn't tell you that whether the temperature or pressure is given for that particular holding time. So to validate the sterilizer, we have to use Bovidic test that is generally used during the first load of your sterilizer, and biological indicator as per NABH guidelines, which should be used once in 15 days. Multi-dose vial policy. So couple of drugs which we use in or we share it for patients like antibiotics, lignocaine, anti-VEGF, mitomycin. We must prepare SOP in which we are supposed to mention how we will ensure safety when we are using in couple of patients, and safe storage after opening of the bottle or vials, and we have to mention the date of opening when we open any vial. Now, infection control program. This manual we are supposed to prepare as per NABH guidelines, and so many points we are supposed to cover, like say standard and universal precautions, which would include your hand hygiene, safe injection practice, any blood or body spillage, needle stick injury, PPE, or even post-exposure prophylaxis, sterilization. You have to define high-risk areas in your hospital. Which all are high-risk areas? Your OT, CSSD, your biomedical waste disposal area. Then there should be a protocols on cleaning, disinfection, and sterilization. There should be a surveillance activities like validation of your machine and cultures. Risk identification and management, we'll discuss this. Antibiotic policy, use policy for certain instruments. Budget. Now your management must have dedicated budget for the hospital, and it demonstrate their interest in executing the infection control practices. KPIs, this is the key performance indicator to monitor all these processes. For example, adherence to hand hygiene. And trainings, frequent trainings on infection control practices is really required. Training is one of the major pillar in NABH. There should be an infection control nurse in your hospital which would supervise all these processes, and would arrange for the trainings. Infection control team, which should include microbiologist as one of the member. This team will make all the policies. An infection control committee. This committee will review all the policies, and it will also discuss any adverse event if it has happened. The committee has to meet once in 4 months. Now, what is risk identification and management or risk reduction protocol? So this is to minimize the chance of infection in eye, and for this we will include all these points, like the surgery prerequisite in case of high-risk surgeries or people who are having who are HIV or HBS positive, and there should be the antibiotic protocol should be included. The preparation of patient before surgery, care during surgery, post-operative care with antibiotics, scheduled follow-up, the early detection of surgical site infection. We must include the disinfection protocol before, in between, and after surgery. There should be a stringent OT etiquette for staff and doctors. Surveillance protocol, key performance indicators, and OT infrastructure as per NABH guidelines. Reuse policy, so couple of instruments like phaco tips, sleeves, vitrectomy cutters, cassettes, we reuse, right? So we have to make SOP, we have to list out all these items which we are supposed to reuse, how many times we'll reuse, and we have to mark the item after every use. And frequent quality check should be done for any kind of damage. There should also be a policy to discard early in case damage happens. Many registers and records are supposed to be maintained in OT, but most important ones are OT culture reports, the sterilizers indicators reports, validation record for all the sterilizers, recall records, consumables used during the surgeries, OT master logbook with implant details, AHU maintenance record, AHU daily log, and your checklist for OT disinfection and OT cleaning record. So now coming to the management in case infection happens. So surgical site infection. So in NABH, the endophthalmitis is also known as surgical site infection, and as per CDC definition, infection occurs within 30 days after the surgery if no implant is left, or within 1 year if implant is in place, is known as SSI. Now protocol, we know, we do complete recall of all the patients, instruments and consumables after sealing the OT. We observe other patients, operator on that day. We need to verify the sterilization indicators and check all your CSST records, re-sterilize all the items, check all your intracameral drugs or consumables used, check register also, and inform the vendor. Check IOL details, redo OT de-infection, and again culture and validation of sterilizer machine is required. And entire thing should be documented in detail with investigations and treatment plan. And do not forget to recheck your consent. Now this end-off is kind of incident, and any incident as per NABH protocol we are supposed to note, or it is reported at incident reporting. And when incident reporting is done, we have to first do root cause analysis and then take some corrective and preventive actions. Now how we do root cause analysis? There are various methods. We'll learn 2 simple methods. One is 5 why method. You keep asking why for couple of times till you get the answer. Now suppose infection has happened. So why infection happened? Because protocol was not followed. Why it happened so? Because there was a lack of awareness. And then last you come to conclusion that there is a lack of communication and callous attitude by the staff. Now how to rectify this? So you have to impart frequent training. Keep taking training, teach your staff and make them understand how important is the infection control practices. Now another method is fishbone analysis, where we break down the root causes. Suppose there is an endophthalmitis, you can see it is the another subgroup is breach in sterilization, where you can include like there was no validation of your sterilizer machine, or there was a failure in indicator, right? Endogenic factors like uncontrolled diabetes, or there was kind of systemic illness, contaminated solutions or drugs. We couldn't find any visible dirt which was ignored. Mixing of sterile and unsterile instruments, or inefficient disinfection. We don't have any protocol in disinfection, or that day the AHU failure was there. Okay. So when adverse event happens, again after doing root cause analysis, we have to take corrective actions and then preventive actions. So what are the corrective actions? We know we treat the patients, we do OT surveillance, CSST surveillance, again instrument, consumables and medicine recall, and prevent actions to prevent infection to be happens again in future. So here we need to change the policy, change your cleaning, disinfection protocol, sterilization and instrument cleaning protocol, change the consumables. You can change your supplier vendor and alert your colleagues regarding the faulty consumable. Document entire process, and during the committee meeting you are supposed to discuss this and make new policies. Again, you must impart training to your staff with new policies and procedure, and the most important thing is review of training effectiveness. So frequent training and their feedback is required from the staff.